So I'm just here to discuss a little bit about how these issues of epistemic injustice might emerge, specifically in a psychiatric context. It's based off some research that I've done over the past year or so. So, first of all, there's probably one core paper that's out there at the moment that discusses epistemic injustice specifically in psychiatry. And this one core paper was written by Paul Crichton, Javi Carrell, and Ian James Kidd, published in the BJ Psych in 2016. And in this, they focus almost entirely on what Kathy was discussing over there as testimonial injustice. Specifically, they try and argue three things. Firstly, that psychiatric service users are at a particularly acute risk of testimonial injustice, particularly in interactions with medical staff. This is in addition to an acute vulnerability that already happens in other kinds of somatic illness. Secondly, medical professionals can enjoy undue credibility inflation. They point out that this might lead to a similar sort of injustice, even in cases where patient testimony is given due weight. I think people may disagree about these things, but this is the point that they make sometimes. And then thirdly, is that they identify two broad kinds of factors that will contribute to these injustices. Firstly, global prejudices about the mentally unwell, including things like many things that are in fact symptomatic. For example, substance abuse or addiction are actually cases of personal vice. Are actually symptoms of personal vice. And secondly, specific prejudices about people with specific diagnoses. For example, that schizophrenic patients are sort of intrinsically or meaningfully violent. Both of these kinds of factors can contribute to undue credibility deflation in psychiatric encounter. And they make a recommendation on the basis of all of this, and they suggest that medical staff should develop certain kinds of virtues. And by virtue, I just mean a disposition to behave in a particular kind of way in interactions with patients. Specifically, they should listen to and respect patient viewpoints in order to counteract any tendency towards injustice. So they should actively seek out to give more credibility to patients' testimony than they would do naturally. That's the idea. So all of that seems somewhat sensible to me. I'm not a medical professional, but all of that seems relatively sensible. And certainly a lot of research in the service user literature and work by service user political movements seems to suggest that at least these risks really do happen. These harms really do occur. But when I first read this paper, I think I had two main questions that really sort of stood out for me. Firstly, it's quite common to think of stigma or prejudice in terms of social structure as well as individual interactions. So we might think that some of these problems go beyond any particular kind of interaction. If we do think that, is that the case in psychiatry? And does that suggest that we need structural remedies rather than just individual remedies, rather than just pinning all this stuff on medical staff and saying, you must develop your virtues? Are there other things that need to be done, either to enable that to happen, or things entirely separate from that? And secondly, and relatedly, this paper focuses on testimonial injustice. They also mention hermeneutical injustice, which is another form of epistemic injustice that Kathy introduced to you. But the question remains, are service users vulnerable to other forms of epistemic injustice as well? And if so, what might analyses that make use of these concepts reveal? Either about ways in which you could reform the psychiatric profession, or alternatively, just getting greater insight into patients' experience of the psychiatric profession. So, after a little while, I think I've got some very tentative answers to both those questions. I'm going to try and spend the rest of my time trying to share those answers with you. So, in answer to the first question, so I say tentative answers up there, so I don't have to be tentative from here on in. You just take it that there's tentativity sort of built into everything that I say. So, the answer is yes and yes. So there are all sorts of systematic or structural failings that might lead to epistemic injustice between psychiatric patients and psychiatric service users, and clinicians. So, firstly, service users often lack access to what we might call socially accepted markers of credibility. So, we have to make judgments about people's credibility all the time. We might think that there's nothing vicious about that. It's just a matter of fact about living in a busy, noisy world where we have to interact with people all the time and come to believe things on the basis of what other people tell us much of the time. There are ways in which we identify which people are credible and which people aren't. We might think there's nothing ethically wrong about most of that, or at least some of it, the ways we do that. But the problem is that the markers that we use aren't justly distributed across the population. People who are underprivileged in various ways, including psychiatric service users, which often sort of cuts across the lines of class, economics, race, sexuality, gender, and so forth, may lack access to the kinds of markers of credibility that we give to people. For example, we tend to, for instance, treat people who are clearly well-dressed and have paid attention to their personal hygiene, probably treat them as generally more credible than people who are dishevelled. That's something that could easily be lost if you're in the grip of a particularly nasty psychiatric issue. There's nothing in general necessarily, maybe we think there is something wrong with that particular example, but there's nothing necessarily wrong about using these markers of credibility, but they're not shared widely enough. And so when we use those when people use those in the clinical encounter, we're going to perpetuate a certain kind of injustice, despite the fact that individually we're not necessarily doing anything wrong. Secondly, service users might also lack access to the kinds of epistemic resources that are necessary to make sense of their experience. So people need certain kinds of language, technical language in particular. They might need certain concepts, so certain ways of thinking about these things. They might need access to research on the condition to understand the condition. They need access to sort of methodologies, sort of like ways they can come to know things themselves about their own condition. They need all of this to sort of fully interpret and understand their own experience. This is just a general point about how we sort of come to know things about ourselves and about the world. But because of the way that psychiatric information tends to be produced and disseminated, a lot of service users will lack access to those kinds of resources specifically relating to their experience, their condition, and so forth. Again, this isn't the responsibility of any single person to communicate. Obviously, a primary clinician should try and communicate as much of this as possible, but this isn't the fault of that. This is a much more sort of broader problem in how we produce, how we sort of like come to know things about psychiatry and how we disseminate that information to the wider population. Those two things. And finally, even when service users sort of, collectively, particularly in service user movements, are able to develop these resources themselves, often in ways that are quite different to the psychiatric profession more broadly, their attempts to communicate these insights to clinicians and service providers are often undervalued. So even when they have access to the right sorts of resources to make sense of their experience, there's no guarantee that those resources will be shared with someone who's responsible for their care. And that can lead to all kinds of misunderstanding and miscommunication. And once again, this isn't necessarily an individual failing of anybody, it's a way in which these resources are distributed, and in which the ability of people to make contributions, how that works. So I think all of that suggests the need for a general overhaul of what sorts of epistemic resources and concepts are shared between service users and medical staff, as well as a kind of epistemic leveling between service users and medical staff. Obviously, I'm not necessarily advocating for anything specific here, but these sorts of reasons speak in favour of those kinds of reforms. And then very quickly, the answer to question 2 doesn't quite make sense because I phrased the second question differently at one point. So just instead of yes and quite a lot in both respects, remove in both respects, yes and quite a lot is the answer to question 2. So let's take an example of, just one example, I think there are lots of other kinds, but let's take the example of testimonial smothering that Kathy talked to talked about it earlier. So I won't recap too much of what Kathy said. But what I will say is that another important aspect to testimonial smothering is that the testimony involved is risky, right? So there is a chance of harm if that testimony is misinterpreted, maybe even if that testimony isn't misinterpreted. It's the sort of thing that creates risk either for the people themselves or for people they love or care about. And if they don't feel that people can handle that risky testimony properly, they will, well, they very often silence themselves. Now, it's hard to identify specific cases of testimonial smothering definitively, because obviously testimonial smothering is marked by an absence of testimony. So it's very hard to know when testimony is absent because of testimonial smothering and when testimony is simply absent for other reasons. But we can at least identify that certain kinds of conditions that, thank you, sorry, very, very quickly, the right kinds of conditions exist in psychiatry. So testimony is indeed risky, and it's risky in part because of the powers that psychiatric professionals have over service users, whether they use these powers appropriately or not. So the powers of detention, powers of enforcing treatment, powers of giving or refusing care, all of these different kinds of risks are present when you're trying to testify about your own symptoms or your own experiences, especially in recent history and sort of crisis care. And so I think that suggests that we need to reevaluate not just how medical staff use the powers granted to them, I think that might be important as well, but what the powers are themselves. Because the mere presence of that power, even when used appropriately, makes the testimony of service users potentially more risky than it needs to be. And on that point, I've hit time, I've gone over time, sorry about that, and I will stop there.
Thanks very much.